We can do that, but when the bandwidth goes down, probably we may turn off our videos.
Yeah, that's perfectly fine. Let's give participants like 20 seconds, 30 seconds to join, and Dr. Abnet will be starting. Thank you.
Good morning, good afternoon, and good evening, everyone, from wherever it is that you're joining us here today. I am delighted to welcome you here to this important webinar on non-communicable diseases, the next frontier for community health workers. And as the Executive Director for the International Institute for Primary Healthcare, I am honored to open this session and set the stage for our discussions today. I will begin by giving a brief introduction about our institute and what we do in these series of webinars, and I will continue introducing our guest of honor, Dr. Patrice Machaba. The Institute was originally established in 2016 by the Ministry of Health to be a center of excellence in primary healthcare. Our mission is to proactively engage and drive the advancement of primary healthcare policy and programming for the attainment of universal health coverage. And we do this by drawing on Ethiopia's rich experience in implementing innovative primary healthcare approaches and community-based health programs at scale, which at the end of the day aligns with the principles of the Astana Declaration and the 2030 Universal Health Coverage targets. With that in mind, our institute is built upon 4 strategic themes, particularly our major areas of focus. The first one is the global primary healthcare support, which provides capacity building and technical assistance to enhance primary healthcare systems worldwide, at which point our webinar fits into this strategic area. The second is the national primary healthcare support that we provide. It's focused on strengthening the Ethiopian primary healthcare system through capacity building, primary healthcare improvement initiatives, and innovative testings in what we call Warada Innovation Centers. The third area of our focus usually revolves around primary healthcare advocacy and partnership. And we do this by promoting primary healthcare as a tool for achieving universal health coverage and developing strategic partnerships with different partners and donors who are in the area of primary healthcare. Our last strategic pillar is knowledge generation and management. We do this by conducting research and disseminating knowledge to inform and influence primary healthcare policy and practice globally. So today's topic is particularly crucial as we explore how community health workers can address non-communicable diseases, which is a priority these days, and it's a growing challenge in low and middle income countries as well. It's not limited to high income countries anymore. Therefore, community health workers are at the front line. They play a pivotal role in managing and preventing these diseases, at which point they strengthen our healthcare system as well. As mentioned before, this webinar is a part of a series organized by our institute aimed at strengthening primary healthcare systems in low and middle income countries. So these sessions generally have been instrumental in driving meaningful discussions and sharing best practices across the globe with a very high engagement and positive feedback from participants, which we're very proud of. So the impact of these webinars have been significant, helping many countries to initiate and improve their primary healthcare strategies. With that being said, it's my absolute pleasure to introduce our distinguished guest speaker, Dr. Patrice Machaba. Dr. Machaba is the former president of the Novartis US Foundation and has held many leadership roles within Novartis, including group head of global health, drug development, and epidemiology. Dr. Machaba has made significant contributions to public health, his work spanning across continents, from running a practice in obstetrics and gynecology in South Africa to teaching systematic reviews and meta-analysis methodologies at the Medical Research Council in Cape Town. Dr. Machaba is also a board member of Last Mile Health, which brings him here today with us, and is also a board advisor for Axmedrix. I apologize if I have brutalized the pronunciation there, but his extensive academic background includes a Bachelor of Science with a distinction in chemistry from the University of Lesotho, a Bachelor of Medicine and Bachelor of Surgery with honors from the University of Zimbabwe, and a Doctor of Science from the University of Stellenbosch. His leadership and insights into global health challenges and opportunities make him the perfect speaker to address the critical role of community health workers in combating NCDs. So it's again, my absolute pleasure, and we are thrilled to have Dr. Machaba here with us today to share his experience and expertise and perspectives in this pressing issue. Please join me in welcoming Dr. Patrice. Thank you, and I hope to find today's session a very insightful and inspiring session.
Thank you so much, Dr. Select, for that very kind introduction. My name is Patrice Machaba. I've also just assumed a new role as the CEO of the Gates Medical Research Institute, and it's truly a pleasure to be here. I want to thank the organizers and the presenters, the Ministry of Health from Ethiopia, our colleagues from Nepal who will also present, and Last Mile Health. There's going to be shared experiences here, both from Ethiopia and Nepal, to show how you can integrate and utilize the skill sets of community health workers and health extension workers. So the lessons we've learned as public health specialists post-COVID is that we need to learn to rapidly adapt to changing healthcare solutions. And you will see that when the COVID pandemic occurred, teams had to pivot because we could not travel. They had to pivot as to how do we connect with our healthcare workers? How do we train our healthcare workers? And how do we look after our patients? So that's the first lesson. The second lesson is that we're fortunate, actually, that during the COVID pandemic, there's also been a boom in different technologies as to how we can communicate to reach our patients and reach their healthcare workers. So we should utilize that. And then the third insight is that once you have those changes happening, it's important to remember that health systems themselves are subject to innovation. Innovation is not just about medicines or technologies. It's also, we need to disrupt the healthcare systems going forward. Now, in March, I was fortunate, very fortunate to spend a week in Ethiopia, a lovely country. It was my third time there. And it was truly outstanding. The only country really that I know with 40,000 health extension workers that when they were selected, they are supervised, they are supported and integrated into the healthcare system. That's really important. No parallel healthcare systems. And then finally, they're actually salaried. That makes a huge difference. Now, it's clear to me now that non-communicable diseases are now at the front line from community health workers. And I saw that in practice in Ethiopia. There was a time, I would say, I started practicing my obstetrics and gynecology at the height of HIV. There was a time when you talked about healthcare and public healthcare, the only discussion was HIV, TB, malaria, dengue, or Chagas if you go to South America. But things have changed. Things have changed clearly. Could you just put up the first slide? I just took this slide out. I only have two short slides. This is a really good database. And you can see the data comes from the WHO, CDC, World Bank, and UN. And you can choose any country you want. And of course, I chose Ethiopia. And look at it says top 50, but I had to cut it down to the top 10 causes of death. Note there, you don't see tuberculosis. You don't see HIV. In fact, HIV is number 19. What you see there, stroke, coronary heart disease, liver disease, diabetes, hypertension, breast cancer, lung disease. So the patterns have changed in Africa. And different countries are at different stages of changing from this infectious disease, epidemic, pandemic, and now we have a rise in non-communicable disease. So this is really critical. So I'm looking forward to the discussion, and the facilitation will be done by a distinguished scientist, Dr. Joseph Yamo. He will be our moderator, really outstanding public health expert. I read his CV. He's not only a practicing physician, he's also an associate professor of the University of San Diego in Ethiopia program. He has had more than 38 scientific publications. And I think recently he was appointed as director of the Tropical Health and Education Trust. So perfectly qualified to guide us and lead the moderation. And with that, I hand it over to you, my brother, Dr. Memo.
Thank you very much, Dr. Machaba, and welcome to Ethiopia. As already Abinat said, this is part of a series of webinars. And the topic today is, as already mentioned by Dr. Machaba, is non-communicable disease. And we are going to see, and it's a very well-chosen theme, the next frontier for health, for community health workers. That's for health extension workers in our context. We will see about the role of community health workers in addressing the burden of major NCDs. We will also share some best experiences in terms of training, and we will see also some evidences from across the ocean, from Nepal. And we will probably talk about some ways forward. As Dr. Machaba has said, we have to disrupt a system and try new ways, innovative ways. We can't just do the same thing over and over again to achieve a different goal. So NCDs, the burden of NCDs is great, as you all know. It is becoming a major cause of deaths globally. And it's rapidly surpassing mother-child health problems, communicable diseases. We can say we are in an era of double epidemic as far as low and middle-income countries are concerned. The health system is straining under the pressure. Individuals, community members are suffering from high out-of-pocket costs and low productivity. But there is a way, always. Humans, we have faced so many challenges, and we have always found ways of at least fighting back. So the WHO 5x5 approach, selecting 5 major NCDs, and also selecting 5 major risk factors that affect them is, I think, a very good start. It does not address 100%, but at least we are halfway. And if we focus on that, prevention still has, as a best time tested strategy, has a role. And in prevention, community health workers, our health extension workers, will have a lot of role. So without wasting any more time, I will introduce our first speaker. He is Dr. Addis Tamre. He is a senior director of health system strengthening at Amref Africa. He is a medical doctor trained in Gondar College of Health Sciences. He has a Master of Public Health from University of South Africa. And he's also trained at Harvard as a transformation specialist and deliverologist. He has a very illustrious career, which I have no time to describe, but I will just highlight his 20 years of experience. But this goes beyond public health into education, finance, and tax. He's an author of 14 articles and 2 books. He has been instrumental in crafting the Ethiopian recent revised health policy, which has almost taken 5 years to be endorsed. And he has been a Director General and Chief of Staff at the Ministry of Health, and has been high-level negotiation with Global Health and PEPFAR operations in the country. He's also been involved in transformative initiative across Ethiopian healthcare system. He now resides in Addis with his family. Without any further delay, I would invite Dr. Addis to deliver his presentation. And I think manage also the video show immediately after your presentation. Thank you. Please take the floor.
Thank you so much, Dr. Yosef, for your kind introduction. I'm really humbled. I'll be taking the next 5 to 10 minutes, talking about the Ethiopian Health Extension Program vis-a-vis its contribution to the NCD and the journey, it has gone through, so that people are able to, participants are able to appreciate its role in the different frontiers, including NCD. And let me share my. So I hope you're. Are you able to see my screen, my presentation? Somebody shout yes.
Yes, we can see with the presenter view.
Yes, go ahead.
All right, thanks so much. Just to start my presentation, the Ethiopian health system is arranged into three tiers. We have, in terms of like the level of care, we have the primary level health care, we have the secondary and tertiary health care. And the primary level health care is something I think, worth talking about, particularly in the context of the community health workers program. So in this care, we have the primary hospitals, the health centers, and the health posts. We have close to 17,000 health posts. These are workstations of the health extension workers, which are nearly 40,000, as Professor Patrick from South Africa spoke earlier. So the reason why I'm showing you this is because, we have something like a very well-structured health service delivery system in Ethiopia, which is primarily anchored on, primary healthcare units at the lowest level, constituting the health center and the health posts. And the health extension program, which is part of the primary healthcare level in Ethiopia, was introduced in 2003. In a moment, I'll be showing you like the detailed journey it has gone through. Since its introduction, the health extension program has actually undergone lots of changes. But the 3 important changes are basically the expansion of the program into pastoralist regions in 2006 and to urban settings in 2009. And the next important change is the shift of the model of the health extension program service delivery from a model family training towards a scale-up approach of involving community engagement through the Women Development Army in 2011. And I think the most important change, which is quite relevant to the discussion that we're having today, is the inclusion of additional packages on curative care and non-communicable diseases to respond to changes in the different areas, including demography, epidemiology, socioeconomic factors, and community demand. So these are very important, 3 changes that have happened over the years since its introduction in 2003. And in this graph, you see that, from its inception to where we are today, the program, the health extension program, has gone through lots of changes. The uniqueness of the health extension program in Ethiopia, or the community health workers program in Ethiopia called HEP, is that the health extension workers are basically recruited and formally trained for a year and deployed to the health posts, and they are on the government payroll. So this is basically a model that is applauded for being, sustainable. And here, the three important probably milestones that I want to talk about are here three. So one is in 2016, as I was alluding earlier, in the introduction of the second generation HEP, the HEP packages were increased from 16 to 18. And this is when the important, packages around curative care and NCDs have been introduced and expanded. And then the other important milestone, I think, in the history of the health extension program, happened in 2019, which basically made the basis for the HEP optimization roadmap in 2020, is a national assessment of the HEP program. So that assessment basically identified all the key important bottlenecks of the health extension program from a system perspective, right? Looking at it from a community engagement perspective, from supply chain, from capacity of health extension workers, from data perspective and all that, and leadership governance, the governance perspective and all that. So that basically led to the revision of the health extension program, and then the health extension program optimization roadmap was launched in 2020. And what happened is that, in this slide you see that there are basically shifts, key shifts, as a result of this optimization. Like, for example, even though the number of packages remain the same, there are some additions in terms of delivery, institutional delivery, comprehensive abortion care, and adult treatment. And there are changes in terms of human resource from the traditional 2 health extension workers per health post density to a multidisciplinary team approach, including nurses, midwives, health officers for comprehensive health posts. So, moving from in addition to having basic health posts, there are also comprehensive health posts, bringing a multidisciplinary team of professionals I just talked about. Infrastructure, there are advancements, again, with this optimization. Governance and financing, there are new introductions, including the establishment of community health program units at the health centers, and out-of-pocket payments and CBHI schemes for adult treatment services in these facilities as well. In terms of community engagement, one of the lowest scores of that assessment, 2019, was along the dimensions of community engagement. And to sort of boost that, the BHL men and youth engagement added on the Women Development Army strategies. So this is to basically show you that this optimization has brought about some opportunities, but at the same time challenges, and I'll be talking about those in a moment. So these are the packages that most of you are very, I think, familiar with. And you have the 18 packages, again, in the basic and comprehensive HEP packages, but there are minor differences around around the adult treatment such as STIs, UTIs, respiratory tract infections, chronic conditions, acute musculoskeletal injuries, and all that in the comprehensive HEP category. So the reason why I sort of pulled out this note from the roadmap is because NCD is an important component of the disease prevention and control package of the health extension program. So there are important aspects of promotion of health and prevention of diseases and management of certain critical illnesses. Like asthma, like type 2 diabetes, hypertension, COPD, and all that. So the question is, like, is HEP the right platform to basically address the rising burden of NCDs in Ethiopia? The quick answer is yes, but with the current state of HEP that we have and with all the current challenges, is it able to optimally deliver that expectation? It's a no. So there are lots of things that need to be, fixed on the health extension program based on the findings of the 2019 national assessment. But in terms of like the platform, in terms of whether or not it's the right strategy, I think that's Ethiopia is on the right trajectory to addressing this burden. So in conclusion, I want to say that skilled, supervised, and supplied community health workers can play a crucial role in reducing premature deaths by implementing effective NCD interventions. I didn't talk about the burden of NCD in Ethiopia, but it's very, very high. And also I didn't talk about the risk factors. The risk factors are huge, whether it's tobacco, whether it's alcohol consumption, whether it's obesity or salt intake or all that. They are huge out there, and they're addressable through this program. So in terms of recommendations, have four important points to talk about. One is, like, the ministry should complete the integration of NCD services, particularly the promotion and prevention services into the community health workers program. So we have that integration on the paper, but we have to make sure that that's actually happening on the ground. So through that, particularly, I repeat this, promotion and prevention are the mainstay of NCD prevention and management in Ethiopia. And it should be, I think, the way forward for many developing countries as well. So that integration should be complete. And second, the community health workers program, were identified as having critical gaps in terms of their skill sets to manage NCDs and some other packages of the health extension program, and integrated refresher trainings on NCDs through different modalities, whether it's in person, digital, blended, need to be there. The third important recommendation is the importance of integration of the NCD trainings on the major communicable diseases, so that we don't have a siloed approach. We have to continue employing the integrated approach to addressing challenges, whether it's NCD, NTD, or communicable diseases or so. So that promotes efficiency and service integration. Fourth, the HEP optimization roadmap is an excellent roadmap, and it's based on challenges identified in 2019 national assessment, and that has to be effectively implemented. And there is a costing to that. It is estimated to cost around, I think $12.6 billion, and in 15 years. And I think that has to be implemented in full. And the last but not least, point that I would like to make is that the non-communicable diseases, prevention, promotion, or management should not be coming at the cost of other important problem categories like family health or communicable problems. So we should continue giving priorities also to family health and communicable diseases as well. Those last words bring me to the end of my presentation. Thank you all for your attention. I'm happy to receive questions at the end. And over to you, Dr. Youssef. We can't hear you. You're on mute.
Oh, thank you, Dr. Adbis. Sorry to rush you up. Anyway, you will have more time for interactive discussion with our attendees. So I will now go directly to the second speaker, Dr. Tsababu. Dr. Tsababu Binyam is the Deputy Director of Last Mile Health, Ethiopia, and he holds a Master of Public Health from Umeå University in Sweden, and a medical doctor again from Golder College of Health Sciences. More than 20 years of very diverse experience in public health with a focus on developing the primary healthcare, bringing equality to healthcare to rural population. He has been involved in initiatives such as primary healthcare transformation, human resource development, Heal TB projects he has led, and also has been an associate researcher at Ethiopian Public Health Association. Currently, he's supporting the Ministry of Health to revolutionize training of health extension workers using digital technologies and a blended learning approach. I think without any further delay, I will give him a chance to present, and then subsequently, I think he has a video show as well. Go ahead, Dr.
Thank you very much, Dr. Youssef, for the kind introduction. I'll share my screen. So thank you again. My presentation will focus on building health extension workers' skills to increase access to non-communicable disease care in Ethiopia. Actually, this is a case study from Ethiopia, and it's based on a project implemented by Last Mile Health in collaboration with the Ministry of Health of Ethiopia. Before I move to the next slides, I would like to say a few words about the health extension program. Actually, Dr. Adbis has already described it in detail, but I would like to make a couple of pointers. The first point is that the health extension program is a flagship program for the Ethiopian government. And we have seen a lot of commitment from the Ethiopian government so that it became an exemplary program across the globe. The other point that I would like to make is that actually health extension workers are credited for significant contribution in improving maternal child health outcomes in the past decade. And as Dr. Adbis said, the health extension package has also now expanded so that there are additional frontiers for health extension workers to address and improve health outcomes in the additional health outcomes in the community. So with this, I'll move my presentation. So when it comes to non-communicable diseases, the burden of non-communicable diseases in Ethiopia is increasing in an alarming rate, and NCDs are currently the leading cause of death in Ethiopia, with an estimated mortality of 554 deaths per 100,000 population. Actually, the major morbidity and mortality cause from NCD in Ethiopia includes cardiovascular diseases, diabetes and kidney diseases, neoplasms, chronic respiratory diseases, digestive diseases, and neurological diseases. To address the growing burden of non-communicable diseases, as Dr. Altis mentioned, the Ministry of Health has integrated NCD services to the health extension program package. So that was one of the important milestones in the evolution of the health extension program. And that happened in 2016. It's now almost 8 years. But as Dr. Adis said, most of the initiatives related to the NCD service delivery at the community level are still at infancy stage. So to address the growing burden of the NCD here in Ethiopia and also initiate the NCD services, the ministry realized that building skills of health extension workers is a key milestone. And to achieve that milestone, the ministry has developed a training material for training of health extension workers on NCDs. So the training module on NCDs are the number of key contents for that are important for prevention of NCD risks, as well as promotion of healthy lifestyle. And also it includes detection of major NCDs through screening and the referral to higher health service levels for management. So most of the contents focus on identification of NCD risk factors and addressing those risk factors, including risk prevention, and also addressing major NCDs, including hypertension, rheumatic heart disease, diabetes mellitus, chronic obstructive pulmonary disease, and asthma. And also there are contents focused on cancer, including breast cancer, cervical cancer, and childhood cancer. There are also contents on eye health, focusing on cataract, glaucoma, and refractive errors. And finally, also contents on mental, neurological, substance use disorders, including psychosis, depression, epilepsy, and also common substance abuse disorders in Ethiopia, including alcoholism and chat chewing. So to make this training effective, Last Mile Health has collaborated with the Ministry of Health to develop an innovative blended learning approach with the aim of improving cost of the training and also saving training time and improving learning outcomes. One of the key challenges identified during the health extension program assessment in 2019 was that the integrated refresher training, the in-service training modality for health extension workers was very costly, and because of that, it was inconsistently delivered. So the innovative blended learning approach was aimed also to address that challenge, and also the skill gap identified during that assessment, so that health extension workers will have a better skill in addressing NCD and other problems at the community level. So as the name implies, the blended learning approach has two components, a self-learning component and also in-person component. And the self-learning component is provided using an app called Extension Essential app. This app is actually an open source app customized for the needs of health extension workers. And it can be accessed using Android devices anywhere, anytime. The only time it needs internet connection is for one-time login and data syncing. Otherwise, it can be accessed offline anytime. So for the self-learning period, we integrated a number of multimedia resources, including illustrations, animation videos, lecture videos, and character stories. Particularly the character stories are stories that shows health extension workers solving problems in their communities. So in addition to learning, they have also motivating factor for health extension workers. So all these multimedia resources integrated for self-learning are in local language with English subtitles, so that health extension workers can easily or can better understand the content of the training during the self-learning period. We also integrated quizzes with instant feedback. Particularly the quizzes are for each sessions, and they are case-based, so that health extension workers can relate to the service they provide. There are also additional contents for self-learning, but during the in-person session, we focus on skills building through different training delivery methods, including role plays, skills demonstrations, and skills practice, group discussions, case scenarios, and other contents. And this in-person training is provided at accredited CPD centers, which are equipped with skill lab materials, so that health extension will have a better opportunity to practice skills. To evaluate also this training, we integrated evaluations, assessments, pre and post, using knowledge questions and also skill assessments, so that we evaluate the outcome of the training. Particularly, skill assessment is integrated for the first time for the integrated refresher training for health extension workers. And we have seen very promising results with the introduction of skills assessment. Actually, these pictures are examples of skills assessment on selected competencies, NCD competencies. The first one is skills assessment on breast examination or breast mass. And the second one is skills assessment in measuring blood pressure for hypertension screening, so that health extension workers practically train and also practically assessed to measure the outcome of the training. So to show you some of the results, we have measured knowledge. Actually, the knowledge assessments are also case-based, so that health extension workers relate the questions with the service delivery, and also it tested their analytical skills. So with the knowledge, we have seen 19 percentage points improvement from pre-training to post-training. So we have seen a significant improvement in the knowledge of health extension workers post-training. We also measured, as I said before, skills of health extension workers on selected competencies to show you. As far as non-communicable diseases are concerned, we measured 5 skills. The first one is the body mass index skill, including anthropometric measurements, body mass index calculation, and interpretation. That has increased by 46% post-training as compared to pre-training. The blood pressure measurement and interpretation skill has improved by 54%. Breast examination measurement using breast model has increased by 51%. Eye examination has improved by 42%. And blood glucose measurement using glucometer has improved by 76%. So since the training is also focusing on skills, we have, and also provided at CPD centers, we have seen very marked improvement on NCD skills post-training as compared to pre-training. These trainings are actually, they are not without challenges. We have seen a number of challenges in initiating NCD services at the community level. This was also previously mentioned by Dr. Addi's presentation. The first challenge is related to training and supervision. Actually, this is the first time that health extension workers received a comprehensive training on NCDs, so that this lack of comprehensive training, as well as lack of supervision on NCDs, is hindering health extension workers' ability to handle the growing burden of the disease effectively, even if the NCD is included as one of the health extension workers package, the health extension program package components. The other challenge we have seen during the training is actually a shortage of equipment and supplies. Particularly, there are essential equipment that are important for screening of common NCDs, including hypertension and diabetes, using blood pressure apparatus and glucometer, and many health posts lack this equipment, so that it poses additional obstacle for delivering and initiating and delivering NCD service at the community. Our project has a very limited scope. Like, we plan to reach 1,541 health extension workers and supervisors. And this is very much limited scope as compared to the total need of the 40,000 health extension workers. So we still see initiating and providing NCD services at the community level in Ethiopia is at infancy stage, and it's a challenge. In conclusion, if health extension workers are skilled, supplied, and supervised, then they will have a potential to make a considerable impact in reducing premature deaths from NCDs by making risk prevention and also healthy lifestyle promotion, screening and detection, and referral of NCDs, and making the service available and accessible at the community level. In terms of next steps, we will leverage existing funding for NCDs, and also we will work to mobilize new fundings to scale up and learning to reach all health extension workers. Actually, as Dr. Addis mentioned also during his recommendation, when we provide the training, we integrate both NCDs and MCDs, so that it's provided as an integrated training, not as a separate only NCD training. If our presentation here focuses on NCDs. The other key next step is also to actually avail the required equipment and supplies for health extension workers, so that they can screen major NCDs at the community level. And also, it's important to strengthen systems for supervision and support, so that health extension workers will have the capacity to initiate and continue NCD services at the community. Let me pause here. Probably you could have a number of questions related to this, but for now, I'd like to say thank you for your attention. Thank you. Back to you, Doctor.
Thank you. Thank you, Dr. Tababu. Sorry again to rush you up. I enjoyed both presentations, but we have more time for you to discuss on your content of your presentation. Is the video ready, case study?
Yes, let me share it.
Yes.
ዛሬ እያደረግን ያለነው ህብረተሰቡ አይን ምርመራ እያደረግን ነው። አይናቸውን የሚያማቸው ሰዎች ከየጎጡ ጠርተን እሱን ምርመራ እያገኘን ነው እየሰጠን ነው ለህብረተሰቡ ማለት ነው። እና ሌላ አገልግሎትም ያው ሱካር ምርመራ፣ የደም ግፊት ምርመራ፣ የተለያየ ምርመራ እያደረግን ነው። ግን አሁን እዚህ በራፍ ላይ እያደረግን ያለ ነው አይን ምርመራ እያደረግን ነው። ከዚህ ምርመራ ለይተን ችግር ያላቸውን ስናገኝ ሪፈር ነው የምናደርገው ወደ ሆስፒታል።
ለታካሚዎች አሁን እዚህ እንዲህ አይነት አገልግሎት ሰርቪስ መኖሩ በጣም ትልቅ ትርጉም አለው ባይነኝነት ጥቅምም አለው። ለምሳሌ አሁን የሆነ የህመም ስሜት ተሰምቷቸው ሐኪም ቤት ለመታከም ሲሄዱ ስንት ነገር እንደሚያስቡ ታውቃለህ? የመንገዱ ርቀት፣ ትራንስፖርቱን፣ እዛ ወረፋ ቶሎ አይደርስም። እንደ ኮሙኒኬብሉ ወዲያው ሳይን ኤንድ ሲምፕተም ስለማያሳዩ የመዘናጋት ሁኔታ አለ።
እዚህ ያለነው ህደ ቃሊቲ ነው። ህደ ቃሊቲ ይኸው ዛሬ እዚህ ደም ምርመራ ታደርጋለህ ብላ ልጅቷን ስለነገረች ነው የመጣሁት። እስቲ አሁን ተመረመርኩ። አሁን በሽታም አገኘው። ይሄ የሚጎዳ ነገር ነው እንዳይጎዳኝ አሁን እግዚአብሔር በዚህ አግኝቼ በዚህ ከለክላለሁ ብዬ መንገድ ያገኘው። ይሄ በጣም ደሳኝ ነው። ቤት ሆነን ነው አገኘነው ማለት ነው። በጣም ደሳኝ
Thank you very much. Now we will proceed to the last presentation, which is going to be delivered by Dr. Yoko Iadaki. She is a physician and a scientist conducting research, community-based research on management of non-communicable diseases in low and middle-income countries. She is an assistant scientist at Johns Hopkins Bloomberg School of Public Health, and she is involved currently on trials and implementation research studies in Nepal and other low-income countries. Dr. Yanaki, please go ahead and make your presentation. Thank you.
Thank you, Dr. Mamo, for a very kind introduction. Good morning, good afternoon, good evening, everyone from everywhere in the world. I'm going to share my screen from now to speak about my experience in Nepal. Let me... sharing my desktop one. Okay, I should be able to share my screen, and I should be sharing my first title screen, but let me know if you are looking at a different screen. So once again, my name is Yoko Inagaki. I'm assistant scientist, a faculty member in the Johns Hopkins University Bloomberg School of Public Health. I have been conducting research studies about task sharing with community health workers to address the burden of NCDs in low-income countries, especially in South Asia, particularly in Nepal. And I'm going to quickly share my experience in Nepal, spending the next 10 minutes. So some of you may be familiar with the country Nepal, some of you may not. So I'm going to quickly explain about the country Nepal. It's a landlocked country in South Asia with a wide variation in altitude. The lowest level would be around 60 meters above sea level, and the highest level would be more than 8,000 meters, which includes the Mount Everest, which is one of the highest mountain in the world. The size of the country is about about the Ethiopia is 8 times greater in terms of the size. So it's a very small country compared to Ethiopia. And the size of population is about quarter of what Ethiopia has. So the population size is also a little smaller than what Ethiopia has. And in terms of the population density, the density is actually twice greater in Nepal. So it's a little, geologically, it's a smaller country with a little more population density compared to what Ethiopia has. It's a multi-ethnic and multi-religious country. A majority of them are Hindu, followed by Buddhism, followed by Islam, and among others. About 40% of them work in agriculture sector. About 20% of them would work in the industry or secondary industry, and the remaining 35% work in the service. More than 70% of them are illiterate. And on the right side, you can see the picture of the country Nepal. And on the red to a brown color area, it's all the mountain. And then they are very cold because it's very high in altitude. So it's almost impossible to do the agricultural work in this area, or the crops doesn't really grow in this area. And on the next light yellow area, which is about plain area or between mountain and close to the sea level. So this is one of the area where agriculture is very popular. And most of the people are currently living in the major cities such as Kathmandu and Pokhara. In the next slide, I'm going to explain about the NCD burden in Nepal. So Nepal is one of the top 10 fastest urbanizing low-income countries across the world. On the right side, you can see the web article explaining more than 60% of Nepali now lives in urban areas. So there has been a lot of migration from rural area to the urban area, which has been one of the acceleration factor of the NCD burden, as many of you already know. And particularly in Nepal, 3 top risk factors are hypertension, smoking, and high blood glucose that you can see on the lower right corner of the picture. And the control of these factors has been pretty challenging. So in terms of the hypertension, only 20% of them know that they have hypertension by being diagnosed. Less than 10% has been under the drug treatment, and about 4% of them have actually under their blood pressure control. In terms of type 2 diabetes, pretty similar to the hypertension. About 25% of them have been diagnosed. About 20% of them is under the medical treatment, and only 6% of them are under control. And this is the slide that I borrowed from the Resolve to Save Lives. That is one of the global initiatives addressing the cardiovascular risk factors globally. They recognize the hurdles to blood pressure control into the 3 categories. One is the diagnosis. The second hurdle would be the treatment, and then the last hurdle will be continuity of the care. And this is, you see some text that I add on top of this slide. And to me, it is very challenging for people to even get to this diagnosis hurdle. First of all, the NCDs are very asymptomatic at the earlier stage. You don't feel anything by being hypertensive, or you don't feel much by early stage of diabetes or any other factors such as COPD. Your symptoms is very minimum. So people that do not necessarily go to the health post or any nearest health facility at the earlier stage of their disease. And the second of all, that this has been the case for many low-income countries, but their nearest facility is very far. It can be so many miles far from where they're living. And the third point that I want to raise is the lack of health workers at the facilities. There has been many peer-reviewed articles indicating that in the low-income countries, it is very challenging even for physicians to see patients at least 3 times in a year, which is not all the patient, but even just for the patient with NCDs. So to me, the current situation of the world is that this is very challenging for many people with NCDs to even get to the diagnosis hurdle. And next, I'm quickly explain about the health systems in Nepal. So the health systems in Nepal is structured into the 4 levels. On the highest level, you see hospitals. In the second level, you see primary health centers. And in the hospital level and the primary health center levels, you will have doctors, nurses, and midwives. And the third level is the urban health centers or health post. The name is different by municipality. And at this third level, you will see facility-based community health workers, such as auxiliary nurse midwives, auxiliary health workers, health assistants. All of them used to be community health workers. And Nepal historically had various community health worker programs, but they kept the female community health volunteers as a community health workers, and they upgraded the remaining community health workers into these three categories: auxiliary nurse midwives, auxiliary health workers, or health assistants. And the last level is community, where community health workers serve. So there has been more than 50,000 female community health volunteers, which we call as FCHVs in short, registered in a country. The workforce size is about 3 times greater than the number of doctors, midwives, and nurses combined. So it's a very big workforce, and then therefore they have been believed as a frontline health workers who can possibly address the burden of NCDs. So in this slide, I'm quickly going to explain about FCHBs in Nepal. So this is a national program, government program established in 1988. They are supposed to be married and have at least one child, and they need to be from the community they serve. So these are the selection criteria in Nepal. They will, if once they are selected, they will undergo 18 days of initial training, and they will have 5 days of refresher training every 5 years. In Nepal, FCHBs are volunteer, so they are not paid, but they will receive some allowance for the transportation, for the uniform, or for other necessary materials. They will conduct regular home visitation with the scope of the following 2 scopes. One is the health education and counseling. They will give the education to the mothers at the periconceptual phase, or the health education for the pregnant woman during the ANC, or the education to the postpartum woman just after giving a birth, or give education to the mothers of children under 5 years of age. Another scope is the distribution of commodities. So you can see the picture of FCHB holding a box. In that box, they would have a vitamin A, condoms, contraceptive pills, iron tablets. They will have the antiseptics for the umbilical cord, ORS and zinc package for diarrhea, or they will have an oral misoprostol for the prevention of PPH, among so many other commodities. And what I can clearly say in terms of the policy and the guideline is that there has been no official roles in NCD control and management for FCHBs at the moment. So the research question that our team, not just myself, but so many other colleagues in my team had is, what if we ask FCHBs to screen before and manage early stage of NCDs in Nepal? And this is a result of one of the studies that our team members did. I wasn't involved in this study, but I am presenting on behalf of so many colleagues, including Dr. Dinesh Nepalni, who published this paper as a first author. So this study was open-label cluster randomized control trial done in Nepal. They recruited adults between 25 to 65 years of age in Nepal, and they provided 5 days training to FCHBs. And then they particularly asked FCHBs to conduct a lifestyle counseling and measure blood pressure with digital device and refer participants with blood pressure higher than 140/90 to the health post. And as a result, they saw the significant reduction in the systolic blood pressure in a normotensive population, pre-hypertensive population, and also in a hypertensive population. So this paper really share the insight that by giving a training to the FCHBs, we can reduce the blood pressure in the community at the population level, not just the people with hypertension, but even among the normal hypertensive population. So this is the first study. And another study that our team members did is addressing the burden of type 2 diabetes. So this was pretty similar to the study that we did with the hypertension. So this was also the open label cluster randomized control trial done in the same area in Nepal. they recruited the adult with fasting plasma glucose higher than 126, or those who has been diagnosed as type 2 diabetes. They gave similar training to the FCHBs for 5 days and asked FCHBs to conduct home visits every 4 months, during which they did the lifestyle counseling, a fasting blood glucose check with a finger prick test, and also asked them to refer those with a high blood glucose to the health post. They saw the statistically significant reduction in the fasting blood glucose at the 12 months follow-up. So this study also indicated that the FCHBs can provide a significant impact on the blood glucose management. And now I am shifting the direction from just Nepal to the global evidence at the moment. So this is the paper done by the colleagues in India. So they did the systematic review and meta-analysis showing, investigating the impact of sharing tasks with community health workers to address hypertension. Some studies, one of the studies are from Nepal, and the other studies are done in mainland China, India, Sri Lanka, Pakistan, and then so many other LMC, low and middle income countries. And then collectively, we have been seeing the impact of task sharing with community health workers in hypertension. So from this study, they concluded that community health workers can reduce systolic blood pressure by at least 3.67 millimercury by conducting meta-analysis, which to me was one of the milestone that the community health worker and then so many researchers done in LMICs. And then by shifting focus from hypertension to type 2 diabetes, there has been little studies investigating the impact of task sharing with community health workers for the control of type 2 diabetes. So we need a little more studies to give more clear conclusion on that. So coming back to this slide again, this is what I personally believe about the role of community health workers. So there are a lot of hurdles and a lot of factors to improve the NCD control. I believe they can do the screening, they can do the diagnosis, and then they can improve the attendance to the clinic appointment by going to the homes, giving a counseling, giving advice to the community members. They could, by training them and then by providing a good device, such as a digital blood pressure device, they can measure the blood pressure or other risk factors correctly. And they can also help community members to increase adherence to the drugs, but it doesn't mean that they can address all the NCD risk factors or all the hurdles to include the NCD control. There are a lot of factors that the policy side or the country side should also make an effort to, such as, for example, even if community health workers are very passionate and very skilled, if there's enough drug that they can distribute, or if there's enough drug in the health post or in other health facilities, we can't collectively improve the risk factor control. Or if the guideline is not strong enough, or if there is no good balance between the private sector versus the public sector, we can't provide the fair and affordable healthcare to everyone in the country. So with this slide, I wanted to point out that the community health workers are very important and crucial factor to improve the NCD control, but that only wouldn't be enough. And then this is to quickly provide the global overview of the policy environment at the moment. So in terms of the hypertension, which is not the case for other NCDs, but particularly for the hypertension, WHO has been recommending that we can share tasks even about the drug treatment with other non-physician professionals, including community health workers. So the policy environment has been changing slowly and then gradually. And then today, the policymakers or global leaders think that we can share the drug treatment tasks with the community health workers and other non-physician professionals. So which itself has been the achievement, but also we collectively believe that there are a lot more to be done from the policy side. So this is the quick summary of my presentation. Sorry if I spoke very fast, but this is my last slide, and I'm happy to take more questions at the end. So I believe that the evidence about task sharing with community health workers has been growing from Nepal and then so many other countries in 11 Cs, but which is only one of the factors we can address to improve NCD control across the globe. And the policy environment has been changing, but not as fast as we want. And the third, we all need to think about the sustainability of a community health worker program. I believe that there are so many type of health professionals, including a medical doctor, which is myself, and so many panelists here. And we can continue to be a medical doctor because there are opportunities to promote our careers. And we need to think the same things about community health workers. What is your next step after being a community health workers? Would there be a degree? Would there be a bachelor's degree? Would there be a master's degree? Would there be a PhD degree to be a community health workers? The retention rate to be a community health worker in Nepal is pretty good. Many of them stay working as a community health worker for about 14 years in their life, and which itself is great. But we also do need to think some motivation and some reasons to stay being a community health workers. Everyone wants to have a better life. Everyone wants to have a higher income. Then there has to be such opportunities for community health workers as well. And particularly for the Nepal, which is different from health extension workers in Ethiopia, they are not paid in the first place. So that has to be changed, I believe. And I personally think that if we do not professionalize the community health worker, this might end up being a temporary solution. So we need to think a lot about what we should do about the category of community health workers as one of the health professionals. I'm going to wrap up my presentation here, and then happy to take more questions at the end. Thank you so much.
Dr. Yoko, I think we have very few, probably 10 minutes for question and answers if we reserve some 5 minutes for organizers to make some closing remark. So what I will suggest is those of you participating, thank you very much and welcome. You can send your question through the chat box, and the presenters will address those questions that are relevant to them. Meanwhile, not to waste time, I'll try to highlight some of the points raised by the presenters and probably ask some simple questions while the rest of you think of questions to ask them. Probably we'll take the first 5 questions. So thank you, Dr. Addis, again, for going through the journey of the health extension program beginning in 2002. It has come a long way from agrarian to pastoralist, from rural to urban. A very good career structure has been shaped for health extension workers. Level 2 training, level 4, and now a degree program in family health. The family health team and the multidisciplinary approach is also a very good development. There are a lot of policy strides that you have illustrated from exclusively prevention. Health extension workers are now involved in delivery services, in treatment, in refill. There is progress from family health team to multidisciplinary team, from just health extension workers. Now in the urban setup, more discipline are involved. There is emergence of the health insurance now, and we are targeting for comprehensive health posts that deliver some basic treatment like refill and others. So there is a lot of development, and Dr. Patrice has earlier mentioned some of the things like these health extension workers are employed, they are supported, supervised, they are salaried, integrated in the system. These are all good symptoms for its sustainability and going strong. But one question I have for you, Dr. Adis, training in family health with a degree program. Of course, what I would say is controversial. Now, if there is too much training, then people don't want to stay in the urban setup, but they go and find jobs in towns. So what will be the challenges with just training? Will there be turnover? Will they be replaced? Or so just keep that in mind. I'll go to Dr. Tababu's presentation. I have been part of the consultative meeting shaping their blended course, and it was very exciting. The animation, the character, this could go beyond health extension worker to be useful to children, and even community members can easily understand it. It saves time and cost and brings better outcome in competency. That's very good. But just my question is, why didn't you achieve that much on the knowledge part? Probably is the content of knowledge, is it too much loaded? Are we teaching them pathophysiology and other interesting but not very useful practical things? What did you, I would like to, your deep insight on that. Dr. Yoko, also thank you. The hurdle you mentioned towards hypertension and diabetes care in Nepal are similar to ours. Asymptomatic nature hinders people from seeking health. The distance is important, transportation cost, waiting a long time, queuing at the health center level, and also, the cost of medicine, it's out of pocket. All these are a lot of problems. Thank you for the studies you've mentioned, but the global study overall does not yet show, you say, much effect of a primary health care intervention. It is quite logical and rational to assume that whatever we are doing is really makes sense, but again, we have to bring the evidences to convince policymakers. So how do you see the challenge there? Research, when are we going to have, really hard data, or are we going to continue or stop? What do you think the role of research would be? So I think I don't see anybody asking questions from our audience. But if you can start commenting on this, Dr. Adis, Dr. Tababu, and Dr. Yoko, turn by turn, we might find some people throwing questions. Thank you.
Thank you, Dr. Yosef. I think you raised an important and practical question as well. Yes, normally, naturally, when people grow along the ladder of professionalism, there is this high tendency of looking for opportunities at personal levels. But I think when we look at the health extension program and the different changes that are being made, we have to see it holistically. One, there is a mindset that the HEP, the primary healthcare, is something that has to be left to low-level professionals, which is completely wrong. So that mentality, has to change over time. That mindset has to change over time. And second is, these people would be forced to leave or forced to migrate to urban settings or so because of several factors. It's not a one-factor situation. It's a multifactorial problem that they are facing. Well, okay, they are trained, they are upgraded, that's one thing, but if they are not supplied, if they are not properly supervised, if the infrastructure they are working in is not there, then it's basically natural that this people, whether they have diplomas or certificates or degrees, basically want to stay there. So looking at it holistically, if we're able to address the different challenges they are facing, and including the motivation, actually, they will be able to, remain there and contribute to the prevention, care, and treatment of diseases, including NCDs. That's what I would say. And migration is normal. Turnover is normal, so far as it's not exceeding certain limits, and that has to be kept in mind as well.
Thank you, Dr. Hadis. Dr. Tubabu, you want to comment? Then we'll go to Dr. Yoko.
Thank you very much, Dr. Yosef. This is a very important question. Actually, this training, as I said before, we measure the outcome using knowledge and skills assessment. Probably, I know that you have participated in the development of the instructional design for the NCD module. Actually, we use ministry content. Our main role is to improve the instructional design so that the content is delivered effectively. But I have some comments why knowledge is a challenge, because we also see some challenges on the training curriculum. One challenge we see that training curriculum is not properly mapped with the health extension workers' scope of practice and also occupational standard. So that sometimes content is outside the health extension workers' scope of practice and occupational standard, particularly in terms of knowledge, is included in the training content. So that's one challenge. The other challenge is the ministry provides this training, develop this training using English, because the in-service training official language from the ministry is English. So that we, in a blended learning approach, most knowledge contents are categorized as self-learning contents, but we tried to make some videos so that could be interactive. At the same time, also, we translated those videos into local language like Amharic, Afan Oromo, even Somali and Afar for other modules, so that health extension workers can comprehend, but still there are contents in English, so that that also will be is the challenge for health extension workers to understand the content, so that we haven't seen a very marked improvement as compared to the skills, but I think the knowledge improvement that's scored on NCDs is also a significant 90 percentage point is not only the improvement. The other point is also that health extension workers are exposed to NCD content for the first time. We have seen other experiences like, for example, RMSH training, and we have seen pre-training knowledge scores are much higher than the NCD scores, while the skill scores are similar to the NCD scores. So our previous trainings were only focused on knowledge, and when health extension workers are exposed repeatedly to trainings like RMSH, then their knowledge will be much higher than skills. So this is the first time that they are exposed to NCD. So that also played a factor in the knowledge improvements. Over from me, back to you, Dr. Yosef.
Thank you, Dr. Tubabu. Dr. Yoko, there is another question from the audience for you. How are the community health extension workers involved in treatment? So somebody is not clear what you mean by, their impact on treatment. So you can add that question to the one I initially asked you about the role of research in gathering evidence. Go ahead, please.
Yes, thank you so much. I think the first question from Dr. Mamu was about the evidence, the landscape about the evidence of task sharing with community health workers. So I believe with that regard, there has been a good amount of evidence that the community health, by giving a training to community health workers and asking them to do the early stage of the NCD management, they can reduce NCD risk factors, particularly about hypertension. I believe many studies have been coming out from South Asia, Southeast Asia, and South America, and probably not that much from Sub-Saharan Africa at the moment, which is based on my own study, which I'm trying to publish now. But I reviewed, I did a scoping review or systematic review to collect all the studies done across the world where community health workers are trained to share tasks for the hypertension management. And I saw a lot of studies from the areas that I mentioned, but not that much from the Sub-Saharan Africa. So there has been a little of geological variation. But in terms of the number of the study, collectively, we have enough evidence, I believe, but not, and then that's about the hypertension, but not, that is not the case for the other risk factors, such as a blood glucose management or the smoking cessation or a breast cancer screening or cervical cancer screening. So there has been some sparse area regarding the evidence in these risk factors. So that is something the academia, including myself and the other panelists here, should make an effort in the future. And then another question from the panelists was about what they did, like what sort of a treatment or what sort of particular roles that the community health worker had to increase or to reduce the blood pressure or to reduce the risk factors. So most of the studies that has been done across the world, they about half of the studies done across the globe, community health worker only did the health education and counseling, and about 40% of them, community health worker also measured the blood pressure, and then I found only 1 or 2 or 3 studies where community health workers refilled the medicines or they initiated the drug treatment. So to summarize about their roles, the particular roles to reduce the risk factors, most of studies has been asking community health workers to do just the health education and counseling. And about 40% of them, community health worker measure blood pressure, and there are only very little study where community health workers are involved in the pharmacological treatment. I'm gonna stop here.
Thank you very much. We have only 2 minutes. Before I conclude, I will take 1 minute. Is there anything the organizer would like to announce? Otherwise, I will use the 2 minutes to conclude. Okay, I will proceed. I think we have a good discussion, but one question from the audience which is not answered is, why are donors not interested in non-communicable disease? Well, there are a lot of donors. Government donors at the moment have their priority on maternal, child, and nutrition. But for example, pharmaceuticals are very much helping, and I should probably thank in Ethiopia, Novartis and AstraZeneca had helped create models of care for NCD in Ethiopia the last 5 or 6 years. So it's good to appreciate that. But as you said, it's not still in the agenda of many of the big donors, government donors we know, but we have to continue to show how it affects the economy and the health of developing countries. So the way forward, I think we have shown us the way forward is innovative capacity building techniques, research, supporting policy formulation through research, evidence, and we have to continue. You know, health extension workers have a lot of load, and we have to continue to innovate new ways of helping them optimize, become efficient and effective, because they have a lot of things to do, 18 packages in Ethiopia alone, and that's very ambitious, and that's also can backfire and could be self-defeating unless we prioritize. So I thank all participants, and time is over. Probably I should give back to Dr. Machaba or Abinnet.
Thank you, Dr. Youssef. I think I would reserve the right offer this opportunity to Dr. Patrice to close, to give the closing remark. Thank you. Dr. Patrice, you're muted if you're speaking.
Oh, can you hear me now? Thank you, Dr. Salag, and thanks to all the speakers. An excellent facilitation, Dr. Mama. I truly believe this is the future. I truly believe that, because if we take an approach in low-income, middle-income countries and use the Western model of trying to train more doctors, more specialists, it's not going to work. We have to integrate healthcare at the community level. And what makes it possible are the point of care diagnostics and the referral system. The key thing is to do what the Ethiopian team is doing. It has to be a permanent job that is salaried and supervised and integrated into the healthcare with a career path. So I am really grateful for all the work that's been done in Nepal, the systematic reviews, the work you are doing in Ethiopia, and more countries should do that. I'll leave you with one example. After independence in Zimbabwe in 1980, our biggest problems at district hospitals was a shortage of anesthesiologists. So there were not enough anesthesiologists during labor when you required an emergency cesarean section. There were 3 or 5 anesthesiologists in the whole country. So we created a 1-year program, selected the best midwives, and taught them regional and general anesthesia. We have more than 100. We need to think like that and disruptively. So congratulations to everybody, a fantastic seminar, and please continue and let's do more of these. And please publish your work so that Dr. Yoko can include it in a systematic review. Thank you, everybody. And thanks, Mr. Chair.
Thank you very much. So it is been a very good presentation. Thank you all presenters and thank you all participants. So the IT man take over.
Thank you, everyone. Bye.
Bye-bye.
Thank you.
Thank you. Have a great day.